Hi, I'm Jacqueline Butsevich, and I'm recording my cerebrovascular accident pathophysiology presentation. The objectives are to identify the epidemiology and etiology of a cerebrovascular accident, or CVA, related important concepts of health to a CVA, characterize the pathophysiological mechanism of a CVA, describe the CVA disease process at the cellular level, describe the CVA disease process at the systems level, and discuss assessment findings to the underlying pathology of a CVA. Cerebrovascular accident overview. A CVA, also referred to as a stroke, is a sudden development of symptoms. The symptoms are dependent on the area of the brain that is affected. The most common symptoms of a CVA are sudden periods of confusion, loss of alertness, of confusion, sudden trouble speaking or understanding, weak facial muscles, sudden trouble seeing in one eye or both eyes, sudden weakness, paralysis, or partial trouble or complete loss of voluntary movements or sensation, numbness, tingling in one arm or one leg or both arm and leg, or a sudden severe complaint of a headache. Any of these findings are the beginning symptoms of a CVA. Each symptom is contingent upon the region within the brain being affected. The symptoms occur due to sudden death of some brain cells due to lack of oxygen when the blood flow to the brain is impaired by blockage or rupture of an artery to the brain. There are two main types of CVAs, or stroke, an ischemic stroke and a hemorrhagic stroke. Both are an interruption of the blood flow to the part of the brain that results in tissue hyperperfusion, tissue hypoxia, and brain cell death. An ischemic CVA occurs 87% in the people, which has an occlusion or a blockage in the vessel in the brain, either by thrombotic or embolic. A hemorrhagic CVA occurs within 10% of the population that has a stroke and is caused by bleeding in the brain or other tissues within the brain from hypertension, overtreatment of anticoagulants, or a weak area in a blood vessel wall. Another type of CVA, which occurs about 3% of the population, is cryptogenic, which is of unknown origin or unknown cause. I will discuss these in much more detail. Epidemiology and etiology of a CVA. CVA is the second most common cause of death worldwide. It is the fourth leading cause of death in the United States. Every 4 minutes, on average, one American dies from a stroke. 130,000 Americans die from stroke each year. 795,000 people in the United States have a stroke each year. Most are new strokes. However, 1 out of 4 are recurrent strokes. 49% of Americans have at least one risk factor for a stroke. 34% of people hospitalized for stroke were under the age of 65, and 87% of strokes are ischemic. Ischemic strokes happen when there's a blood vessel to the brain that's blocked either by plaque, rupture, embolism, embolic, or thrombotic. Stroke is the leading cause of disability. In adults, 90% of survivors have a residual effect. Moderate to severe disability is seen at about 70% of the population of survivors. An estimated 15 to 30% of stroke survivors are permanently disabled, and 20% require institutional care 3 months post-stroke. And a CVA or stroke can happen at anyone at any age. Nearly 1 out of every 18 deaths is caused by a CVA. The American Heart Association estimates that there are currently over 7 million stroke survivors in the United States. CVA diagnosis estimates costs results in $36.5 billion in the United States in 2010, and healthcare costs are expected to triple by 2030 for adults ranging in the ages of 65 to 79 years old. Etiology of a CVA starts with the onset of symptoms, last known well, and there is no set of events prior to having a CVA. And again, who is affected by a CVA? Anyone at any age. And it individually depends upon where the CVA or the stroke is and how it can or will affect their symptoms or deficits. Common CVA's occurrence are within the first year of life, right before or right after birth for an infant. CVA incidence rises with age, especially after the age of 55 and 65 years of age or older. Concepts affected by a CVA. According to Giddens, the interrelated concepts of a CVA are an alteration or impairment of cognition, mobility, hormonal regulation, gas exchange, perfusion, and I'm going to talk a little bit more about a subcondition, hypertension. The concept affected by a CVA or stroke happens when there is an interruption of the blood flow to an area of the brain that causes tissue hypoperfusion, tissue hypoxemia, and brain cell death. An ischemic stroke can be caused by embolic or thrombotic reasons. A hemorrhagic stroke is hemorrhage in the intercerebral, which is in the brain tissue, interventricular in the ventricles from a ruptured aneurysm, or subarachnoid hemorrhage, which is in the subarachnoid space. Cognition is the process involving the understanding of knowledge and thought. Cognition or mental status is dependent upon an optimally functioning brain. When a person has a CVA or stroke, there is an alteration in the brain's proper functioning. Assessing a patient's cognition could be challenging for nurses or for a practitioner. Cognitively impaired patients demonstrate deficits in intellectual functioning. A patient can have a metabolic or a physiological factor that they are experiencing that can also alter a patient's cognition. The brain controls movement, sensation, perception, coordination, and balance. So mobility is dependent upon the optimally functioning brain also. When a CVA or stroke occurs, there is an alteration in the brain functioning. Depending upon the area involved, depends upon where the impairment will be. Alterations in mobility will impair proper body function, which can lead to inability to move an arm, a leg, or both an arm and leg. In return, the improper body function can also cause incoordination, impairments in physical mobilities that can also have a decline in cognitive functioning. A practitioner assessing a patient's functional ability or their capability, a practitioner also will assess their functional status, their actual performance, and to the extreme opposite, a practitioner will assess functional impairment or inabilities, or their best motor response should be appraised. Utilizing a collaborative team approach to care is beneficial when assessing in plan of care, maintaining the functionality in current status and ability. Hormonal regulation can also affect the symptoms of a stroke by metabolic or physiological changes happening with the patient, which can include regulation of glucose, adequate nutrition, appropriate gas exchange, and sufficient perfusion. Hyperglycemia or diabetes mellitus is also associated with thermogenesis, enhancement of increased platelet aggregation, adhesiveness, and decreasing fibrinolytic activity. There can be multiple underlying causes or triggers that may be associated with a number of variabilities, such as acute risk factors or new development of dehydration that can cause alteration in thought process, electrolyte imbalances, hypoxemia, acute infection or fever, being deprived of sleep, effects from or after a trauma, side effects of medication, or taking illicit drugs. The brain cannot store glucose, but it needs a constant supply as needed to maintain proper functioning. Hyperglycemia can also augment problems of confusion or delirium, increase the blood-brain barrier permeability. So it's best to assess patients' glucoses for tight glycemic control to make sure that they don't mimic or mask any neurological symptoms. Gas exchange and sufficient adequate perfusion are very closely related. A CVA mainly origination is an impairment of gas exchange and perfusion. Alteration in gas exchange and perfusion is primarily cause of a stroke. Basic body gas exchange is oxygen and carbon dioxide. The body uses internal compensatory mechanisms to try to maintain homeostasis. The body will spontaneously hyperventilate, causing vasoconstriction when the body is retaining carbon dioxide, which is a potent vasodilator. So it will blow off the extra CO2 to help reoxygenate by hyperventilating to equalize the carbon dioxide and the oxygen levels. One major cause of alteration is in perfusion is during an ischemic stroke is the interruption of the blood supply to the area within the brain. Usually causes are embolic or thrombotic. Loss of cerebral blood flow results in tissue hyperperfusion, tissue hypoxia, and cellular death. A major cause is atrial fibrillation, which causes 1 out of every 6 strokes. Atrial fibrillation is also known as AFib, is the cause of electrical irregularity, disorganization, and disruption of the normal synchrony of a heartbeat, which can be completely asymptomatic for a patient. AFib causes an irregular heartbeat and affects blood flow through the heart. Pooling of blood, causing stagnation of blood within the heart chambers, increases the likelihood of clot formation, which can then break off and then travel to occlude a major brain vessel, causing an ischemic stroke. Hypertension is one of the major causes and risk factors of having an ischemic stroke or hemorrhagic stroke. 1 out of 3 people in the United States has hypertension. One of the most common induced disorders to stress and anxiety is hypertension. Hypertension is the major contributing factor to a hemorrhagic stroke. And also hypertension can be asymptomatic. The golden standard diagnosis of hypertension is monitoring blood pressure readings or trending readings if elevated. Hypertension is considered when there is a persistent systolic blood pressure greater than 140 millimeters of mercury or greater, and or a diastolic blood pressure greater than 90 millimeters of mercury or greater. Persistent elevated blood pressure increases the workload of the heart and can cause damage to the endothelium lining of the heart that can contribute to atherosclerosis. The overall risk factors of hypertension increases with age. Utilizing a collaborative team approach is beneficial when assisting in the plan of caring for a patient to obtain optimal review of systems to provide the best care. Watching their cognition, assessing their mobility, continuously assessing their hormonal regulation, their gas exchange, and perfusion. Another modifiable risk factor is patients' lifestyles. Patients that have lifestyles of eating a diet high in saturated fats, trans fats, or cholesterol can raise their blood cholesterol levels. Eating a diet high in salt and can increase their blood pressure. Eating a diet high in calories can lead to obesity. Physical activity or inactivity. Smoking, excessive alcohol or alcohol abuse, and illicit drug can also increase the risks for having a CVA. Eating a heart-healthy diet, making sure that they have multiple servings of fresh fruit and vegetables throughout a day, a diet low in fat, low cholesterol, maintaining a healthy weight, make sure your BMI is less than 25, going for yearly physical exams, following up with the doctor for checkups, monitoring your heart rate, your rhythm, and your blood pressure, exercising for 30 minutes 5 times a day, not smoking, and alcohol in moderation, and avoiding illicit drugs. CVA pathophysiology. The pathology of a CVA, ischemic or hemorrhagic, is again, there is an interruption of the blood flow to the part of the brain that results in tissue hyperperfusion, hypoxia, and brain cell death. Ischemic stroke process initiates by a sudden interruption of the blood flow by a thrombus formation in the vessel, platelet aggregation, process contained by exposed subendothelium. The platelets release adenosine diphosphate, ADP, that causes platelet aggregation and consolidation of platelet accumulation. Thromboxane A2 is released from the platelet aggregation, contributing to the platelet aggregation and causing vasoconstriction. The damage to the vessel activates the coagulation cascade that can lead to thrombin production, causing cell necrosis. Thrombin converts into fibrinogen to fibrin, which can lead to clot formation as fibrin molecules, platelets, and blood cells aggregate. CVA or stroke pathophysiology concept activates a cascade of cellular consequences. There are complex and dynamic responses to excitotoxicity, mitochondrial dysfunction, and oxidative stressors. Excitotoxicity and calcium overload are the key contributors to early stages of cellular demise. The lack of nutrients available to the neurons after the stroke disrupts the ionic gradients, resulting in excess release of excitatory amino acids, mainly glutamate, driving an extracellular calcium influx and causing in motion atopic and necrotic pathways. Mitochondrial reserves for pro-atopic and anti-apoptotic proteins and cytochrome C experience dysfunction secondary to the calcium accumulation. Mitochondrial damage enables the release of cytochrome C, which activates the capsase-dependent cellular death pathways. Reactive oxygen specimens are produced by the mitochondria have been implemented in reperfusion damage following a stroke. Oxidative and nitrosative stress via free radicals are important mediators for stroke damage that can inhibit recovery. The cellular environment modulates single transduction cascade that tip the balance between pro-death and pro-survival pathways. Reactive oxygen specimens and reactive nitrogen specimens, peroxynitrate, act directly on the executors of cell damage. The release of necrotic cells induce atopsis and inflammatory cytokines that cause a death of the cells in the vicinity of the infarction that aggravates the brain injury. Other contributors to stroke pathophysiology are protein misfolding as a result of excess calcium, glial damage, and a broader pro-inflammatory reaction. Cellular insults incurred following a stroke, neural circuits are also disrupted due to the shifts of the excitation and inhibition balance in the neural networks. The gamma aminobutyric acid, or the GABA, is a neurotransmitter that sends chemical messages through the brain and the nervous system and is involved in regulating communication between brain cells. The role of the GABA is to inhibit or reduce the activity of the neurons or the nerve cells. Modulation of the tonic inhibition regulate GABA receptors has shown to facilitate functional recovery. The unaffected contralesional hemisphere can also influence the excitatory state of the damaged hemisphere, contributing to the destruction of the blood-brain barrier. Improved regulation and a well-developed understanding of how the excitatory inhibitory balance is disrupted after having a stroke is critical to designing therapeutic approaches in stroke recovery. Every component of the pathophysiology response following a stroke on either the cellular and circuit levels represent an opportunity for limiting initial injury and hastening recovery. The diversity of having a stroke and patient-specific characteristics such as contralaterals and vascular composition, patient selection is critical for the ultimate success of their rehabilitation. Researchers gain an insight and ability to manipulate multiple recovery pathways that are effective for neuroprotective therapies will emerge. And then just a little overview of hemorrhagic stroke processes. Initiates by bleeding within the brain tissue with surrounding space resulting in compression. The bleeding can stop or continue to enlarge. Arterial hypertension causes hyaline degeneration and fibrinoid necrosis in the weakened arteries that supply the brain. Brain tissue swelling and damage results in inflammation and edema caused by thrombin and other blood products. that can lead to the Monroe-Kelly doctrine, which is the interrelationship of the volume and the compliance in the brain. The brain tissue is 80%, blood is 10%, and the cerebral spinal fluid is 10%. Components within the skull have an effect on increasing an intracranial pressure that can lead to herniation. So one compensates for the other. So if there's an increase of brain tissue due to bleeding, then it will compress and alter and shift the blood in the CSF fluid. Major complications of either type of stroke is that either type of stroke is a medical emergency for optimal outcomes. Immediate identification of onset of and manner of stroke is determinant of the proper treatment. A stat CAT scan needs to be completed so that immediately as the patient arrives to the ER with symptoms to identify what type of stroke the patient is having. Early signs are that they just sudden onset of weakness or numbness or tingling, and then I will explain more about worsening symptoms and furthering worsening symptoms. A complete neurological assessment, which is assessing their cognition, alertness to lethargic, obtunded, stupor, or coma, orientation to person, place, time, and situation, pupillary response to light, equal, round, regular, irregular accommodation, and reactiveness, brisk to sluggish or fixed. Assess extraocular movements to make sure that they don't have a field cut, change in their vision, blurred vision, double vision, diplopia, any deviation of their eyes, or both eyes conjugate, or their eyes can be disconjugate, or one can be disconjugate. Assess for facial symmetry to make sure that their smile is equal, that they don't have any labial folds, or if there's asymmetry or drooping. Assess their tongue to make sure that it's midline or if it deviates to the right or the left. Assess their cranial nerves, their speech, so it's clear, spontaneous, and logical, or if their speech is slurred, garbled, or if the patient is having expressive aphasia, receptive aphasia. Assess the patient's extremities for motor, strength, range of motion, movement of their extremities, if they have any tremors, coordination. There's an assessment test that you do finger to nose and heel shin test. Assess their balance, their sensory, touch by the pinprick if it's sharp or dull, or wisp of cotton for pressure. Do a vibration test to make sure that they are equally having sensation. Do a temperature test of hot or cold. Assess proprioception to know if their thumb is pointing up or down, or their foot or their toe is pointing up or down. Assess for any numbness, tingling, paralysis, neuralgia, dizziness, fainting, confusion, change in any memory, any hearing deficits, balance, gait changes or dysfunction, changes in their chewing or swallowing abilities. Usually a speech therapist will do an evaluation to assess that. Assess the Glasgow Coma Scale, assessing their eyes opening, their verbal response, and motor response. Complete a National Institute of Health Stroke Scale. It's called an NIH Stroke Scale, mainly for ischemic CVAs, which can be done either for ischemic or hemorrhagic strokes. It is a 42-point scale that quantifies neurological deficits, that is a prognostic tool to identify potential outcomes assessed daily of their functioning ability, or usually at the change of shift, or on discharge also. Acute complications of an ischemic or hemorrhagic stroke are management of symptoms. Mainly in the intensive care unit, we do hourly neuro checks, assessing for any prevention of complications such as cerebral edema, elevated intracranial pressure, seizures, prevention of hemorrhagic conversion from ischemic if they were given TPA and they were only ischemic and now they started to bleed from that, or rebleeding from a hemorrhagic stroke, or increase in bleeding. The treatment of an ischemic stroke is limited to the thrombotic therapy, if applicable, for the management of their symptoms, and the treatment of hemorrhagic stroke is the rapid neurointensive care, identifying the cause of the hemorrhagic stroke, controlling the factors, and minimizing further brain damage, maintaining adequate oxygenation, breathing, and circulation. In hemorrhagic strokes, prevention of complication, avoiding recurrent bleeding, could also have surgical intervention to remove the blood in the brain, or the interventional radiology can assess coiling or clipping of an aneurysm, or they can go for surgical intervention of clipping also. And the optimal outcomes is resolving of all symptoms with no residual effects or deficits, returning back to normal state of being independent, or to the extreme effects, worsening of symptoms that they could be alert and oriented, that they can slowly get lethargic, to stupor, subtunded to comatose. Their pupils can be brisk, reactive, then they can, worsening of their symptoms, become sluggish, and then further worsening symptoms that their pupils are fixed and dilated. Their speech can be clear, spontaneous, and appropriate. They can start to have some slurring, or that they can completely go aphasic, that they say no words at all. Patients can have some movement of their affected side, their arm or their leg, and then they could have deterioration, worsening of symptoms where that arm would get weaker to only having abnormal extension or abnormal flexion of the extremity with peripheral stimuli. So the extremes of also effects of devastating stroke is non-reversible brain damage, needing to be intubated, that they're breathing on their own, and then they can decompensate and need to have oxygen on, or then they can go to that they can't protect their own airway, they need to be intubated. Depending upon the effects where in the brain the stroke has caused the damage, and they can go from moving the one side to being completely paralyzed, independent, needing 24-hour health care, rehabilitation, or living in a skilled nursing facility requiring a trach and a feeding tube. Links to assessment findings of a CVA. I'm going to begin with integumentary. You do a complete physical assessment of checking their skin for color, make sure it's intact, their temperature, make sure there's no pressure points to avoid any breakdown. Patients that have CVAs may develop edema due to immobility or recent falls causing ecchymosis, skin tears, or breakdown, and also to notice any change in colors or if there's any odor from their possible wounds. Subjectively, the patient may complain of weakness, unable to lift or move one side by themselves. Objective findings develop skin breakdown or ecchymosis, or the skin tear. The head, eyes, ears, nose, and throat, or the head and the neck. Patients may complain of headaches depending upon the location. You always want to do a complete assessment of the patient, assessing their hearing, their visual acuity for any changes, and also and if they have any speech impairments or speech difficulties, by doing a complete assessment, inspecting their visual acuity, assessing their sclera for color or any abnormalities, assessing their pupillary response with light to make sure that it's brisk and reactive. If they have any blurred vision or double vision, ask if they wear glasses or contacts, assess their nose for any problems of obstruction or sinus pain, do an auditory assessment to assess with an otoscope to see if there's any abnormalities of their tympanic membranes, assess for any hearing deficits or if they are hard of hearing or if they use a hearing aid, and assess by auscultation and palpation their carotids for any bruits or if they any carotid blockage or anything like that. And with the head, ear, eyes, nose, and throat, you always want to do a complete cranial nerve assessment. Subjective complaints of a patient might be that they have some difficulty seeing or has visual problems or difficulty reading, blurred vision, double vision, and assess their hearing to see if they are able to answer questions correctly or if they may not answer you because they have hearing deficit. Objectively, patients may have visual neglect or a field cut due to where their CVA is, and patients can develop deviation of their eyes, that they don't cross midline. So you want to assess their extraocular movements, assess their peripheral visions for any deficits or any abnormalities. Ask the patient if they have experienced any difficulties with complaints of headaches, dizziness, neck stiffness, and you also want to assess their reflexes, their cough, their gag, and their corneals. The lung and thorax, you're going to assess for any dyspnea or tachypnea. Auscultate their breath sounds for any adventitious breath sounds, any wheezing or rales or coarse breath sounds for congestion. You want to see if they have a productive cough or any mucus. CVA or stroke patients are at risk for aspiration pneumonia, so you always want to assess and review if there's a chest x-ray for results. Subjective complaints a patient may have is some shortness of breath or difficulty breathing. Objective complaints of a patient observed are tachypnea or hyperventilation due to the compensatory mechanism to rid extra carbon dioxide buildup so that they don't have any impaired cognition or develop any delirium from being hypoxic. Cardiovascular system, assess their heart for rate, rhythm, auscultate, and check their pulses for if they're regular or irregular. Assess their heart for atrial fibrillation or any other cardiac irregularities. Tachycardia or bradycardia. You want to listen to heart tones for S1, S2, or abnormal sounds like a murmur, click, gallop, and palpate all their pulses to make sure that they're having good perfusion. Assess their vital signs, their blood pressure, their heart rate for any abnormalities. Check the blood pressure for hypertension or hypertension. Review their EKG results. CVA patients can develop irregular arrhythmias, and it depends on what part of the brain that the stroke is involved that caused the stroke to have cardiovascular problems. Subjectively, patients can feel their heart racing or skips or beats with PVCs or PACs. Objectively, you want to check their heart rate, bradycardia, tachycardia, irregularities, and for AFib. The breast and axilla, no common findings. Their abdomen, you want to assess and inspect, auscultate, percuss, and palpation of any changes in their appetite, recent weight gain or weight loss, any problems with their digestion, nausea, vomiting, or any symptoms of diarrhea or constipation. Patients with post-CVA or stroke can have incontinence, so you want to assess for any changes in their normal bowel habits. If they can't answer the questions, you could always ask their family members. So you want to assess bowel sounds for any distension, know their normal bowel habits, their eating and nutrition to make sure that they're eating balanced diet. And if they aren't, patients that have a CVA or stroke can develop dysphagia, the inability that they can't eat, so they, in the intensive care unit, we insert a Dobhoff tube, which is a small bore feeding tube, so they can receive their medications in their tube feedings. Patients can have subjective feelings of feeling hungry, bloated, constipated. Objective findings of the abdomen is assessing for any distension, if it's rigid or firm. If they're constipated and haven't moved their bowels in a couple of days, they may need some assistance with a laxative to help them move along. Genitalia, anus, rectum, and prostate, no common findings. Peripheral vascular, you want to inspect, palpate their pulses, assess the color, their temperature, movement, sensation to make sure that they're not having any subjective complaints of numbness, tingling, neuralgia. Objectively, you want to make sure that both bilaterally their skin color is adequate, that they're not having any cyanosis or any redness or having any problems with edema and slowing of nail bed circulation to make sure that they're having good perfusion. Musculoskeletal system, you want to also again check their strengths, their movements, their motion, muscle tones, any joint stiffness or pain from arthritis, or you want to check their reflexes in all four extremities for any weakness or deficit. CVA patients develop weakness or deficit depending upon where the involvement happens within the brain. Subjective feelings a patient may have is having weakness on one side of the body, or numbness or tingling, or that they are unable to feel that side. Objective findings, an extremity is weak or is flaccid, depending upon where the involvement of the stroke is. And then nervous system. Nervous system, you want to do a complete assessment, again, of their alertness, their responsiveness, their orientation, cognition, pupillary response, visual impairments, speech or trouble talking, expressive or receptive aphasia, changes in their speech, facial symmetry, tongue position, dysarthria. Again, assess their cranial nerve assessment for motor and strength, range of motion, movement of extremities, if there's any tremors, coordination, their finger, nose, and the heel, shin, if there's any incoordination of those, of their extremities. Checking the temperature sensation again, proprioception. Assess for any impairments. Again, assessing for the ischemic stroke, the NIH stroke scale. Subjective, you want to make sure that they're able to move their hand and arm and leg and feel. Objectively, assess their strengths in all extremities and their cranial nerves. The burden of a stroke is experienced by patients, their families around the globe. The complex pathophysiology of this disease has hindered efforts to augment functional recovery. Neurorestoration must remain a critical objective in stroke recovery and research, including cell-based therapies and neuromodulations, are the two fields that demonstrate the biggest promises in promoting recovery. Neurorestoration can manifest a new direction in providing stroke care. Here's my resources. I went to the American Stroke Association and I utilized both of our books, The Giddens and Costello and Burns, and I also researched and got some peer-reviewed articles by Azita et al. And Bowden and Dosenberg. If you have any questions, I'd gladly love to answer them. And thank you for watching my video.